So today we're going to be talking about the Renin Angiotensin Aldosterone system, also known as RAS, and its effect on blood pressure. And to start, we're going to start with a little bit of renal anatomy first. So the kidneys, or the renal system, the primary function is maintaining a stable volume, electrolyte composition, and osmolarity of the ECF, which osmolarity is the solute concentration. So the smallest functional unit of the kidney is known as the nephron. This is where the filtering of the blood is going to be happening. It has a vascular component and it has a tubular component. So the vascular component is composed of a few different anatomical structures. So first we have the afferent arteriole. This is what is going to be carrying the blood into the nephron and specifically into the glomerulus. So the glomerulus is a tuft of capillaries. This is where filtering the plasma into the tubular component takes place. About 20% of the plasma actually gets filtered into the tubules. The rest of the 80% continue out of the glomerulus through the efferent arterioles. And then we also have the peritubular capillaries, which are going to supply the renal tissue. They're involved in the exchanges with the fluid in the tubular lumen component. So then our tubular component, we have the Bowman's capsule. So this is where the glomerulus kind of fits in. It's like a C cup double-lined structure. This is going to allow the fluid and the plasma to enter the tubules. So then you have the proximal tubule. This is where you have uncontrolled reabsorption and secretion of selected substances. You have your loop of Henle, which is where it establishes an osmotic gradient in the renal medulla, which is important for the kidney's ability to produce urine of varying concentration. Then you have the distal tubule and collecting duct. This is going to be involved in the controlled reabsorption of sodium and water. And then you have the juxtaglomerular apparatus. This is going to produce substances involved in the control of kidney function, which we will get more into that a little bit later. So the renal function is broken down into kind of three sections here. So you have the glomerular filtration. This is when the plasma is filtered from the arterioles into the tubules. And that is, again, going to be taking place in the glomerulus and the Bowman's capsule. Like I said before, 20% of the plasma that enters the glomerulus is actually filtered. The rest, the other 80%, will then leave through the efferent arteriole, but then that plasma is involved in tubular reabsorption and tubular filtration, which are the other two functions here. So tubular reabsorption is when fluids and substrates that are needed are reabsorbed. So this is anything that kind of was taken out during the glomerular filtration that needs to be kind of put back into the blood. And then we have tubular filtration, which is extraction of materials that were not filtered by the glomerulus are then gotten rid of in the urine. All right, so glomerular filtration is pressure driven. So glomerular capillary blood pressure is the major force. So this is the force of the blood in that afferent arteriole heading into that glomerulus. It has to be a certain pressure coming in to be able to kind of push that plasma and filtrate it through to the Bowman's capsule. The glomerular filtration rate is about 125 milliliters per minute on average. And changes in this GFR will result mainly from changes in the glomerular capillary blood pressure. So the two other pressures that we have are the plasma colloid osmotic pressure and the Bowman's capsule hydrostatic pressure, these are going to be things that are opposing filtration. So if that glomerular capillary blood pressure coming in isn't high enough, it won't be enough to have a net filtration pressure that's going to force that plasma out of the arterioles and into the Bowman's capsule. So this then brings us to, what if that pressure is not high enough? What is something that your body can do? So you have a renin angiotensin aldosterone system. This is going to be activated in response to a fall in that arterial blood pressure that we were just referring to, but also in a fall of sodium chloride concentration or ECF volume. So how this process works, renin is going to be released from the granular cells of the juxtaglomerular apparatus. This is excreted into the blood. Once it's in the blood, renin actually acts as an enzyme to convert angiotensinogen, which is something that's normally found in high concentrations in your blood plasma. It's secreted and created by the liver. Once this angiotensinogen comes into contact with the renin, it is converted to angiotensin 1. Angiotensin 1 is then in the blood. When it gets to the lungs, there is a high amount of what's called angiotensin converting enzyme, or ACE, found in the lung capillaries. So once this angiotensin comes into contact with this ACE enzyme, it is converted to angiotensin 2. Angiotensin 2 is then what's going to kind of put into motion the different responses that we're looking for that are going to be able to respond to that drop in sodium chloride, the drop in the ECF volume, and the drop in the arterial blood pressure. And those responses are stimulating the adrenal cortex, which is going to release aldosterone. It's going to increase vasopressin, increase thirst, and increase arterial vasoconstriction. So what does that mean? This is what that means. So when aldosterone is released, aldosterone actually increases the sodium reabsorption, which will result in water retention and cause a rise in the arterial blood pressure. It's going to increase vasopressin, which vasopressin increases the water reabsorption in the tubules, which again, any kind of increase in fluid or water reabsorption will cause a rise in arterial pressure. It's going to increase thirst, which will increase your fluid intake, which again, an increase in fluid is going to cause a rise in arterial pressure, and then it's going to cause arterial vasoconstriction. So this is a narrowing of the blood vessels, which is going to increase pressure. And you can kind of see all that outlined on the right here. That has the renin angiotensin aldosterone set up, kind of laid out, so you can see which organ it's coming from and the order that all the reactions are taking place. And then again, those angiotensin 2, what it's stimulating, which is going to help correct the drop in sodium chloride, ECF volume, and arterial blood pressure. So there is something known as renal artery stenosis. This is when you have stenosis of the artery that's feeding the kidney. So without adequate blood supply, the RAS system is activated, which is going to raise the blood pressure to maintain adequate flow. So symptoms for this are going to be a sudden increase in blood pressure that is hard to control, worsening kidney function with treatment, and treatment-resistant heart failure. So what's happening is, your kidney is sensing that there's this drop in blood pressure, which is due to that narrowing or the stenosis of the renal artery. So it can't fix the stenosis, but what it can fix is the pressure of that blood coming into the glomerulus. And what it does is it activates that system. It increases the blood pressure in your body to maintain that flow. Now, this is something that is a, quick fix, but it's not something that your body can maintain over time. So it's important to be able to identify that a patient has renal artery stenosis, because if you're just treating the high blood pressure, what happens is you give them this, what's called an ACE inhibitor. So it's going to inhibit that ACE enzyme from converting angiotensin 1 to angiotensin 2. So it'll lower the blood pressure of the patient. However, now what's happening is you're going to have decreased flow to that kidney. So you're not going to have good kidney function. So that's why you're going to have worsening kidney function when you're treating that high blood pressure. The high blood pressure is also hard to control because as you're giving medication to kind of help with the blood pressure, your body is still trying to increase that response to the decrease in pressure from the glomerulus. And it's also going to be starting to cause heart failure because your heart is trying to increase this blood pressure, but again, it's not something that it can withstand. So interestingly enough, there is actually an exam that they can do to identify if a person has renal artery stenosis. This is called a captopril-renogram study. It's a nuclear medicine exam. So the patient will come in for a renal function exam, which is something that's normally done on a patient. They're just looking to see if the left and the right kidney are functioning at about 50-50% is where you should be. These exams are done for multiple reasons, but first they have to have this normal renal scan. A patient will then be given an ACE inhibitor, and then the scan is repeated. So what they're looking for is if the patient does have renal artery stenosis, the non-ACE inhibitor exam will be normal because, you know, you have this increased blood pressure, which is going to cause normal blood flow to both kidneys. So it should look like both kidneys are functioning normal. However, when you give them an ACE inhibitor, then the exam will be abnormal because you're going to have that decreased blood flow to the kidney that's affected by that renal artery stenosis, which is going to have decrease in function of that kidney. They won't be able to filter out the radioactive material as well. So the images on the left here, you have the image on the far left is a normal renal scan. It shows increased, it shows uptake in both the left and the right kidney pretty uniformly. And then the image on the right, you can see when comparing that left kidney, this is a posterior image. So the left kidney is not showing up, which means that this is going to be a positive scan for renal artery stenosis. So it is important to know about what this system is, how it's responding, because it's something where a patient might come in with high blood pressure. And a lot of times physicians aren't really sure what's causing the high blood pressure, but being able to say that, it is caused by this would change the treatment. They could go in, they could put a stent in, they could, kind of open that narrowing of the kidney. That should resolve the blood pressure and then be able to maintain the patient's kidney function and cardiac function and keep them actually off blood pressure medication by being able to treat the cause of it. And these are the references that were used in this presentation. Thank you.